Hello, everybody, and welcome to Chapter 7. This chapter is focused on immunity. Again, this is just to supplement the learning that we had in class. That way, you have a full lecture to listen to. And please excuse if you hear some baby voices. This is my child, and I have to record this while she's here, so please don't mind her talking. So the immune system is really important. This system is responsible for our body defenses against things that are foreign to us or those things that would cause diseases, or otherwise known as pathogens. We have a non-specific immune response as well as a specific immune response. So when we talk about non-specific immune response, the best thing to think about is our inflammatory response. And the reason why is because our body, regardless of what the substance is, and no matter how many times that substance is presented to us at different time points, the body will not remember that antigen, and essentially it will react the same. So when we talk about a non-specific immune response, this is the body responding to different cells, toxins, substances, proteins, again, that are perceived as dangerous. Again, we look at inflammation as our example of that. Whereas when we talk about our specific immune response, this is where we have the body remember the antigen that was once presented at one point in time. So again, it will react to substances that are known as foreign to the body, but the difference is that we have specific antibodies that are developed, and these antibodies help us with the remembering of the antigen. That way we have a more robust and aggressive response to the immune system. Here's our reminder slide of the components of the immune system. Again, I won't waste a lot of time reviewing the anatomy and physiology. The main thing I want you to remember is the bone marrow and the thymus. Where we have the bone marrow, this is where our B cells or our B lymphocytes are matured, whereas our T lymphocytes are matured in the thymus. And on the picture, you see where the bone marrow is located versus where the thymus is. Other components of the immune system include the lymph nodes, spleen, tonsils, lymphatic circulation. Again, you do have your lymphocytes and macrophages that are associated with it, as well as your chemical mediators such as histamine and interleukins, which will become important later. We will review some of the different components of the immune system. As I've mentioned, you do have antigens, and this would include self-antigens versus non-self antigens. You have different cells that are associated with the immune system, such as your B lymphocytes, your T lymphocytes, B cells, macrophages. You have antibodies, which are also known as immunoglobulins. I'll refer to these as IG, and then you have a letter that would be associated with those antibodies. You have the complement system as well as chemical mediators. The first thing to note is that you do have self-antigens, and this is how the body tolerates itself. So you do have major histocompatibility proteins or MHC proteins, which help you label your cells. Generally, when you have these MHC proteins, they help the body recognize the self, and eventually the immune system will not attack itself once it recognizes these MHC proteins. So again, this is a way for the body to develop tolerance. Whereas you have non-self antigens, and this is where you have an antigen that is foreign to the body. So these antigens obviously don't have these MHC proteins, which would allow the body to recognize it. So in absence of these proteins, you'll have the body pretty much attack these antigens. And when we talk about antigens, it's also important to note that sometimes the book will use the term immunogens. This is a synonymous term for a foreign substance or a microbe that would stimulate the immune response. And they are made of different types of molecules. You have proteins that make these up, polysaccharides, glycoproteins, and again, they normally appear on the surface of the cell. So please make sure you understand the difference between a self-antigen, which helps with tolerance, versus non-self antigens, which is what would stimulate the immune response. As I've mentioned before, you do have different elements of the immune system, particularly with your cells. You have your T lymphocytes versus your B lymphocytes, and of course your macrophages. When we have our macrophages, these are the ones that are more so associated with just the non-specific response. These are the white blood cells that help with phagocytosis, and they basically engulf foreign material. And these are still activated regardless of if this antigen has been presented before. So again, there's no memory of it. It's just that the macrophages help engulf them and eventually will destroy that foreign material. T lymphocytes, however, they are very specific white blood cells, and specifically these are associated with cell-mediated immunity. You do have three different types of T cells. You have those cytotoxic T killer cells or cytotoxic T cells. These are also known as your CD8 cells. And then you have your helper T cells, which are also known as the CD4 cells. That one will become important later. And then, of course, you have your memory T cells. Again, you do have three different types of T lymphocytes, and all of these are associated with cell-mediated immunity. You have B lymphocytes, which are more so associated with the humoral immune response. And this is just a different branch of immunity. And this is the part of the immune response that helps the body remember. Normally, with your B lymphocytes, you do have the creation of antibodies, which is what would help the immune system remember that it was exposed to a foreign body at some point. And then it would also help to mount a more aggressive response. So you have plasma B cells, which are the ones that actually create the antibodies. And then you have memory B cells, which would pretty much clone plasma cells, but they also help mount a more aggressive response. So B lymphocytes, again, are stimulated in the bone marrow versus your T lymphocytes are stimulated in your thymus. This is an excellent chart to go back and look at. It pretty much discusses what we just talked about, how your thymus helps to develop the T cells versus your bone marrow helping to develop those B cells. And again, you do have various types of T cells. You have those helper T cells, memory T cells, suppressor T cells, and cytotoxic T cells. Whereas on the B cell side, humoral immunity side, you do have antibodies that are developed and you have memory B cells. And again, please note that plasma B cells are the one that help to stimulate antibody production. So you do have different antibodies that would be developed within the body. I do want you to go back and look at all of these in detail. You have 5 that you should be committing to memory. The first one is IgG, and this one is the most common one in the blood, and I mean IgG as in goat. This one is normally produced in a primary and secondary response, but this one also helps to create passive immunity. This one is most easily crossing the placenta. Yes, you can get this in the breast milk, but this one's specific to newborns that are in utero or in the womb. And this one also helps to activate complement. The next one I want to talk about is IgM, M as in moon, and you have this antibody that normally creates an immune response. Normally, if we had the choice between IgG and IgM, IgM is going to be the first one to create the immune response, and then IgG, as in goat, creates the secondary response. IgM is also involved with your incompatibility reactions when it comes to blood, and this one also activates complement, so that's something that IgG and IgM share. Again, if there was an immune response, normally it's first associated with IgM, and then IgG is to follow with the secondary response, but both of these help to activate complement. The next one is IgA, and IgA is specific to breast milk. But this one can also be found in your mucous membranes. It could be found in tears. It could be found in saliva. But most notably, this one is found in breast milk. So you can get that passive immunity from IgA. It's just that the infant will get this outside of the womb with breast milk. IgG can be found in breast milk, but the most notable component would be IgA. But both of them would help with passive immunity. Then you have IgE, E as an egg, and this one is more so involved with your hypersensitivity reaction type 1 or the allergic response, also known as anaphylaxis, and you can have anaphylactic shock that is associated with this immunoglobulin. This one also results in inflammation. And then you have IgD as in dog. This one is attached to your B cells, and this one's more so associated with the humoral response. As I've mentioned, the complement system is also a part of your immune system, and this one, when we talk about complement, it's normally activated with IgG and or IgM. And basically, this is a group of proteins that help to further inflammation. Normally, the complement system helps with cell damage. And when we talk about cell damage, we're talking about damage to those pathogens that are not supposed to be there. When we have complement, it generally works like a clotting cascade in that once one is activated, then the next factors are activated. I'm not necessarily focused on you knowing C1 through C9, but do know that once complement has started and once it's activated, it will continue to activate other components similar to that clotting cascade until we achieve that immune and inflammatory response that the body needs. So the next thing we'll talk about is your chemical mediators, and you have so many chemical mediators. They are listed to the right. You have complement, histamine, kinins, you have prostaglandins, cytokines, you have your tumor necrosis factor and chemotactic factors. The one that I want you to pay attention to is histamine at a later time, because histamine will be more so associated with our inflammatory responses as we talked about. But do know that when we have cytokine storm, this is where we have messengers that help with the inflammation and the immune response, but we have basically an overstimulation of the immune response. So we have something called cytokine storm, or otherwise known as hypercytokinemia, where you have circulating or excessive circulating cytokines in the blood. Again, this one can be triggered by infectious or non-infectious agents such as H1N1, that is a virus, or it can be triggered by COVID. Regardless, please understand that this is streaming from an excessive amount of cytokines outside of the normal requirement for the body. This is an excellent table, and I would recommend going back through and reviewing this table because it goes back through and it does highlight the major components of the immune system and the functions. Again, it does list it by definition. I would go back and look at table 7.1 as necessary. It'll help really break those mediators down. These are just your generalized diagnostic tests when it comes to immunity. One of the main ones that we assess for in the clinical environment are titers, and this is measuring the levels of serum antibodies or immunoglobulins against certain disease processes. You do have the indirect Coombs test that helps to detect Rh blood incompatibility. This helps us to determine the blood types, if it would be compatible with a patient that has certain Rh factors. And then you have the ELISA test that helps to detect HIV antibodies specifically, but it can be used for other diseases, but most notably it is for HIV. And then you have MHC typing, and this one is more specific to transplant. If you remember, MHC is a protein that exists on the outside of our cells, and normally it helps with self-recognition. So the MHC typing should be very similar before transplantation occurs, and this test just helps us confirm that. As I've mentioned, you do have two different types of immunity that we would focus on. Humoral immunity is more so on that B lymphocyte side. Again, B lymphocytes that are produced in the bone marrow. These antibodies are produced to protect the body. So you do have humoral immunity that's associated with your B lymphocytes. You have cell-mediated immunity, or CMI, and this one is more so focused on the T lymphocyte side. Again, T, these are differentiated in the thymus, and these are your cells that are programmed to attack foreign substances. So it's important to note that you do have different types of immunity, and this slide is focused on acquiring immunity. So how do we get our immune response? So of course we're born with a natural immunity, and this one is species specific. And then you have an innate immunity, which is more so specific to our ethnicity and genes that we cannot change. When we have natural versus innate immunity, sometimes this works together and we have a better immune response, versus sometimes we may not have as great of an immune response. So when we talk about this, it's important to note the different types of immunity that we have and how that can affect us overall. The next thing I want to talk about is primary response. And this is where you have a first exposure to an antigen. Normally, when you get exposed to an antigen, your natural immunity or innate immunity will react. And if you are exposed, more oftentimes than not, it takes a couple of weeks for you to develop antibodies to go against that specific disease process. This is why when we get vaccinated, our primary response is not until a couple of weeks later where they'll have you come back and redraw your titers to make sure that the efficacy has worked. So again, when it comes to your primary response, this is when you first get vaccinated or even are first exposed to an antigen. Again, not alive. More oftentimes, if it's a vaccination, it's dead. And you take a couple of weeks to get efficacy or where your titers are achievable. The next thing you have is a repeat or secondary response, right? This is where you have the same antigen, but your body now remembers and has developed those antibodies. So now it knows, hey, this is a foreign substance, and I need to make sure that I protect myself from that foreign substance. Normally, when you have this rapid response, it's more effective within 1 to 3 days. So this slide is just highlighting how you have two different categories of immunity. You have active immunity versus passive, and then there are two categories that fall up under there. You have that natural and artificial. When you have active natural immunity, of course, this is just your natural exposure to an antigen without anything being injected into you or intentionally exposed. Where you have that active artificial immunity, where you have intentional injection of the antigen to hopefully help boost the stimulation of antibodies. You have that passive natural immunity where this one's specific to IgG, and the one that we talk about is where this one is transferred from mother to fetus. Now again, this one is most likely to cross the placenta in utero. So again, you can get it through breast milk, but in the early stages of life, we see IgG develop and cross the placenta in utero. And then you have that passive artificial immunity where you have not the body developing its own antibodies, but you have antibodies that are injected into the body. So this is more short-term protection because the body isn't doing the work itself. It actually has the injection of the antibody for you. Here are some examples of what we just talked about. So that natural active immunity, this is an example with, let's say, chickenpox, whereas when you have artificial active, this is that influenza immunization or maybe even the measles vaccine. You have that natural passive immunity where you have placental passage during pregnancy or breast milk. Again, please make sure you remember IgG is specific through passage during pregnancy in utero versus IgA, which would be the ingestion of breast milk only. And then you have the artificial passive where you have gamma globulins if you had a recent exposure to a microbe, and you have antibodies that are injected inside of you. So really there is a purpose for immunizations. As I've mentioned before, everyone has a right to reject vaccination. This is not the purpose of this slide. More so just to talk about why we do encourage vaccinations. We do want to hopefully encourage a phenomenon called herd immunity, where you have a high percentage of the population that is vaccinated against said disease, or maybe has already experienced the disease process, and thus if they have either the injection or have already had infection, that means they have developed antibodies to this disease process. We hopefully will help decrease the spread of that disease. An example of that would be your smallpox or even the COVID-19 vaccination, so on and so forth. We even try to do this yearly with the influenza vaccination. So now you have the resurgence of outbreaks because you do have a population that has not had a lot of vaccines against measles and mumps. You do see a resurgence of measles and mumps in today's time. They are also working on different vaccinations against tuberculosis, AIDS, malaria, and others. And a lot of research is being conducted on genetic vaccines as well. Unfortunately, this does lead into the concept of reemerging infectious diseases. As I've stated, you have the measles and mumps that have been under control at one point, but now we have had outbreaks. But again, there's not a consistent in vaccinations. Sometimes you do have globalization where it has spread. You do have resistance to different drugs, and you do have just the factors that a combination of these can present the reemergence of an infectious disease. You do also have emerging infectious disease processes. Again, COVID-19 would fall up under this category because it's newly identified, and we had not had to experience this until the previous 5 years. One would imagine that COVID-19 was a form of bioterrorism, and this is where you use biological agents to attack civilians and or military personnel. Although the purpose of this lecture is not to point fingers and to decide if COVID-19 was truly an act of bioterrorism or not, it is one to just take note of that because it was engineered in a lab and it eventually outbroke from that lab. There are individuals that think that it was a form of bioterrorism due to the devastating effects that it had on the world. We're not here to claim that it is versus not, but it did cause a pandemic and it did send anxiety for this reason. So again, you can have agents that are engineered in these closed settings, again, laboratories, that are supposed to hopefully stay where they are, that can get loose and get out, and they can become very infectious, not only just endemically or within a certain population, but it can spread globally. So again, bioterrorism was a thought and a very realistic thought for some individuals when it came to this concept. So we're switching gears here. We're going to talk about tissue and organ transplants, and particularly rejection, which would be the pathophysiological issues with transplants, okay? So the first thing we'll start with is talking about the different types of tissue transplants. You have allografts where you're transferring between the same species. That could be pig to pig, cow to cow, human to human. Whereas you have a very specific isograft where you're transferring material between two identical bodies and specifically identical twins. So the way it's an isograft is that they have to genetically be the same. You have an autograft where you're transferring tissue from one part of one individual to the same individual. So you could transfer from skin, you can transfer from different organs, you could transfer from different tissues to bone. All of that would be considered an autograft. And then you have a xenograft where you're transferring between two different species. For example, pig to human. You can go from pig to cow, cow to human, so on and so forth. That would be a xenograft. In all of these cases, these tissues must be compatible, and it does have to be essentially tested to make sure that it will last. When those tissues and organs are not compatible, you have rejection, but it's important to note that you have different types of rejections. You have hyperacute rejection, which generally occurs immediately after transplantation. Normally, this happens during the surgery. Then you have acute rejection, which can happen after the surgery up to a few weeks after the surgery. And then you have late rejection, which can happen a month or a couple of years after the transplanted. And again, this can go for tissues and organs. Anytime there is a transplant, again, you run the risk of rejection. So the way that we best treat that is through a process called immunosuppression. And all immunosuppression is that it's a way to help reduce that immune response to help prevent rejection. So we have different drug treatments that will help, such as prednisone. You have cyclosporin, which is a biologic. You have azathioprine, which is another biologic. And again, when you suppress the immune system, one thing that you have to think about is that you do run the risk of having infection and opportunistic organisms affect that individual. So it's very important not only to watch for signs and symptoms of transplant rejection, but also make sure you watch for risk of infection. Next, we'll talk about hypersensitivity reactions, and there are 4 that I want you to know about. Here are your hypersensitivity type reactions. Again, they're listed type 1 through type 4. And the first one we'll talk about is your allergic reaction or type 1 hypersensitivity. The main thing about this one is that it can be a medical emergency when it turns into anaphylaxis or anaphylactic shock. The immunoglobulin or antibody that is most associated with it is IgE. And the best way to treat this is to prevent or remove the causative mechanism. And please note that anything can be a causative mechanism or otherwise known as an allergen. Then you have your hypersensitivity type 2. This one we more so associate with incompatible blood transfusions. Again, you have someone that has A blood that has received B blood or AB blood because they're not compatible due to that B component. You have someone with B blood that's received AB blood or A blood, and that's not compatible. Normally, when you have this reaction, the immunoglobulin that's most associated with this one is IgG, G as in goat. Normally, when you have this incompatibility reaction, there are varying types and varying sensitivities, but main thing is that you do have incompatibility with your blood transfusion. The next one that you have is your type 3 hypersensitivity reaction, otherwise known as your rheumatoid arthritis type. Another name for this would be your antibody antigen immune complex. And these complexes literally form a new molecule. Again, these are called immune antigen complexes, and these are deposited in tissues, which will cause an inflammatory response and ultimately destruction of your tissues. The next one that we'll talk about is your type 4 hypersensitivity test or the tuberculin skin test. This one is more so associated with the destruction of your antigen. There is a delayed response due to your T lymphocytes. The T lymphocytes take a little while to mount a response with this. You also do have an inflammatory response that's associated with this type 4. The next few slides will help us go over these in detail, and do make sure that you review table 7.5 as a review. Okay, so next we have the type 3 hypersensitivity reaction, and this is where you have a complex that forms with the antigen and antibody. Again, these complexes literally form a new molecule that then deposits into tissues and joints, which eventually cause inflammation and destruction of that area. And yes, you do see necrosis that occurs from that. One of the examples would be rheumatoid arthritis, but you also have farmer's lung where they get that from inhaling hay. And you also get that from serum sickness. Last but not least, you have the type 4 hypersensitivity reaction, and this one is a delayed hypersensitivity or cell-mediated hypersensitivity reaction. This one is more so focused on your T lymphocytes. And what happens is that they release those chemical mediators that hopefully result in the inflammatory response that would destroy the antigen. So an example of this would be your tuberculin skin test. So the reason why they ask you to come back a couple of days later is that your body is not going to react once it's first injected. It does take a couple of days for your body to recognize that this foreign substance is in the body, particularly in the tuberculin skin test in this example. And what happens is that the body will eventually mount a response to it. But again, it does take a couple of days. Normally 48 hours, we do see a response in that injection site should not have any swelling. It shouldn't be red. It shouldn't have any evidence that you were injected at that site. If you do have inflammation at that site, that does indicate a positive result. So next we'll talk about some autoimmune disorders. It's important to note that autoimmune disorders is where you develop antibodies against yourself. So these are also known as autoantibodies. And again, these are antibodies that are formed against self antigens, not non-self antigens, self antigens, and this will result in your loss of self-tolerance. Unfortunately, the autoimmune disorder not only affects one organ, but in some cases it can affect multiple organs, tissues, and it can be a generalized response. You do have different examples of autoimmune disorders such as lupus erythematosus, which is what we'll talk about today. You have Hashimoto's, you have rheumatic fever, myasthenia gravis, scleroderma, pernicious anemia. All of these would result in the body developing autoantibodies, again, antibodies against self antigens, which will result in loss of self tolerance. So again, this one is a very familiar disease. You may even know someone that has lupus, but again, the official name is systemic lupus erythematosus, SLE, and this is a chronic inflammatory disease and a chronic autoimmune disorder. It does affect several organs. It can affect the kidneys, it can affect the skin, it can affect all kinds of areas, even down to your joints. One of the characteristic tall tale signs that you have lupus is that you have a butterfly rash across the face, and the incidence is higher in Asians, Hispanics, African Americans, and Native Americans. So the pathophysiology is that you do have a large number of autoantibodies against the self. They create antibodies against your self's DNA, your own erythrocytes, hence erythematosus. These are your red blood cells, and even platelets. You can even form immune complexes, which is interesting. So it does kind of fall under hypersensitivity reaction type 3, but we will not talk about it in this light. I just want you to understand it as an autoimmune disorder at this time. But again, those deposits go into the tissues. You can have inflammation of your joints, tissues, and ultimately necrosis. You can get some vasculitis, which is inflammation of the vasculature in your tissues and in many organs. And again, this can impair your blood supply to the tissues. Some signs and symptoms include generalized feelings of unwell or malaise or generalized tired feeling. You can have arthralgias, which is joint pain. You can have cardiovascular problems as well as kidney problems. You can have polyuria. And some diagnostic tests would be looking at your CBC, of course. You would also look at serum antibodies, LE cells, additional blood work. But more oftentimes when we treat this, you do have to have steroid therapy, and to treat the pain, we'll look at anti-inflammatory drugs as well as prednisone to help with the inflammatory response. So you do have common manifestations of lupus, as I've mentioned a few earlier, but I do want to go into detail about those signs and symptoms. You can have arthralgias all over the body, so it's not just centralized to one joint. You can have polyarthritis, so that's multiple joints that can be affected. You can get that butterfly rash on the skin, and it can also lead into photosensitivity. You can also get ulcerations in the mouth and also get hair loss. With the kidneys, you can get glomerulonephritis, which we'll talk about a little later this term. But basically, you have deposits in your kidney glomerulus, which will cause inflammation. And unfortunately, it does cause renal damage. And these individuals can go into chronic kidney failure and unfortunately can go into dialysis. You have lung issues where you can have inflammation within your chest cavity. These can cause chest pain. You can have carditis or inflammation of any of your layers in the heart. Normally it's pericarditis. You can have issues with your blood vessels, also known as Raynaud's phenomenon, where you have spasms in the fingers and toes, and that is accompanied with color change in your fingers and toes. You can have issues with your central nervous system, such as mood changes, depression, even as far as seizures if it's that severe. And of course, you can have issues with the bone marrow. So you have leukopenia, which is decreased white cell count, thrombocytopenia, which is your decreased platelets, and you can have decreased hemoglobin levels, or otherwise known as anemia. Now you have immunodeficiency, and this is where the immune system no longer functions appropriately. And this can be secondary to autoimmune disorder, or it can be secondary to disease process, or the development of another issue with your disease pattern. So when we talk about immunodeficiency, it does come with its own list of issues. You can have partial or total loss of one or more parts of your immune system. That's the cells, that's complement, that's the regulatory components, B cells, T cells, any of that, right? So ultimately, your body is not able to fight off infection as well as it could, which does increase your risk of infection and cancer. It's important to note that you do have primary and secondary immunodeficiencies. Primary occurs when you're just born with a developmental issue somewhere in the system, whereas secondary, you get that from specific causes or infectious processes, and it can occur at any time during the lifespan. So that would be the difference between primary and secondary. Again, regardless of if it's a primary immunodeficiency or secondary, um, it does unfortunately lead you to developing opportunistic infections. So these are infections that can be caused by normal flora, which normally would not cause an infection had your immune system been appropriately functioning. So it is difficult to treat because when you have immunodeficiency, these infections become more aggressive for these individuals because they don't have anything to work with. Most times, if an individual has immunodeficiency, we do try to give them vaccinations or antimicrobial drugs even prior to invasive procedures to hopefully help stop the spread of infection in these individuals. So a disease process that we talked about earlier was HIV and AIDS. So I want to make this very clear that most people don't die from having HIV virus. They die from complications from AIDS or having acquired immunodeficiency syndrome. Again, HIV is a virus that can lay dormant for years, even 5, 8, 10 years before it develops enough for you to be having a detectable viral load. HIV-1 and HIV-2 are different subsets of HIV, and of course, both of them lead to AIDS, but these are just geographically different. HIV-1 is normally located in Europe and the US, whereas HIV-2 is normally located in Africa. More oftentimes than not, you're identified as HIV positive, or your viral load of HIV virus is high enough to be detected, and then eventually this develops into age. But if you start therapy when you are diagnosed and first become positive, normally development of AIDS decreases and you can live a longer span of life. When you have HIV, again, there is no immunosuppression yet. You just have the virus in your body. But eventually, this HIV virus, it destroys your CD4 cells or your helper T cells. And remember, we talked about helper T cells earlier in this lecture. These are your cells that are differentiated in the thymus. You have several types of T cells, but again, you have those CD8 and CD4s. HIV specifically attacks CD4 cells, and because it's a virus, it uses the CD4 machinery to help proliferate or grow until it eventually lyses that cell. So next thing you have is that once these CD4 cells are attacked, you do increase your susceptibility for infection because you don't have helper T cells that are available to help identify the virus and to help proliferate a more aggressive immune response. Um, so the development of HIV and AIDS depends on how early you are diagnosed, but ultimately, if you do not get treatment, again, these CD4 cells are attacked in larger numbers, and eventually it spreads throughout the individual's body. Antivirals that are specific to HIV do help with decreasing that viral load and hopefully not spreading it. So most times people do not die from HIV itself. Again, it's the complications through AIDS. And again, this is where you have significant immune response deficit. Normally, you get HIV through shared needles, through drug usage. You can get it through unprotected sex, regardless of if you have homosexual or heterosexual relations. You can get it through vaginal fluids, blood. You can also get it from mother to infant. And it's also important to note that HIV is not transmitted by touching, kissing, unless you have open wounds in your mouth, sneezing, coughing, toilet seats, eating utensils, or insect bites. You do have to have the presence of the HIV infection, and normally they do a blood test, the ELISA, to test for HIV antibodies. And normally it is a three-stage process. They make sure that you have the presence of HIV, and then they have to differentiate it between, is it HIV-1, which is normally located in Europe and the US, versus HIV-2, which is normally located in Africa. And then they make sure they use a nucleic acid test, and particularly for RNA, to determine if it's a false positive or a false negative. So they do run a three-step process just to make sure that you are indeed HIV positive. Again, I've talked about the pathophysiology. It does affect those CD4 cells, those helper T lymphocytes, which affects both cell-mediated and humoral immunity, because those cells specifically help get both of those components, and they communicate between the two immunities. So again, it does cause them to reproduce and eventually lyse or break up, and then that's how the HIV is spread throughout the body. When we talk about signs and symptoms, once it does progress, you do see your lymph nodes that will increase. You do have fatigue and weakness, arthralgias or joint pains. Sometimes you'll see GI effects, as well as encephalopathy, confusion, nervous system. Sometimes they do call this AIDS dementia, but again, that's associated with increased confusion and just restlessness. Um, and sometimes you do have direct infection of the brain cells by HIV. Normally, we treat HIV with antiviral drugs, not antibiotics. Antibiotics treat the opportunistic infection, not the HIV itself. So you may see individuals on both therapies for that reason. You may see them on protease inhibitors, fusion inhibitors, CCR5 antagonists, nucleoside reverse transcriptase are most notable, and non-nucleoside reverse transcriptase inhibitors. So all of these would be potential treatment methods for HIV/AIDS. I love this slide because it kind of puts the effect of AIDS into perspective. So again, you do have that AIDS dementia or memory loss, confusion. You can get candida in the mouth, or thrush. You can also get herpes simplex, which is another virus. You can get viremia due to HIV, so that can be a form of sepsis. You have your lymph nodes that are getting swollen. You have pneumocystitis jeronis or carini, tuberculosis. You can also get diarrhea or GI disturbances, infection, wasting, anorexia, and of course you can get dermatitis, itching, infections, and Kaposi sarcoma, which is where you have the spots that develop on the body as a result of having AIDS. Okay, so again, most people die not necessarily from the HIV itself, but from complications of AIDS. This is more so because you have ineffective treatment. You can die from pneumocystitis carini or Giardiasis. You have herpes simplex, candida, again, that's that mouth sore. You can get tuberculosis. But again, the primary cause of death is more so because there's an infection that has developed that's more severe than normal. Sometimes you do see AIDS in tandem with different cancers, and they are unusual cancers such as non-Hodgkin's lymphoma, which we'll talk about later in this term. You can also get Kaposi sarcoma, which you have the skin, mucous membranes, and internal organs that develop these spots. Non-Hodgkin's lymphoma, that's more so in the lymphatic system, and you do get these patches that can be brown or purple, and then eventually they swell and become nodular. That concludes this section. Thank you so much for listening.